So very good morning to all of you, and we will now start the session 3, which is titled as Back of the Eye Non-Infectious. I welcome my chairpersons, Dr. Francisco Prichi, Dr. Vishali Gupta, and my co-moderator, Dr. Abhilasha. So I need to take.
I thank the AIOS Scientific Committee for this Uveitis Subspecialty Day and a very interesting program. I first invite Dr. Vijay Tomar to give his talk on pattern identification in choroiditis. Dr. Vijay is a senior consultant in Chitrakoot Eye Hospital.
No, I was at Sitapur Eye Hospital.
Sorry, Sitapur Eye Hospital. I'm sorry for that.
So, good morning, everybody. Thank you, AIOS, for giving me a chance in this academic feast related with cells and flair. So, in our day-to-day clinical practice, we encounter the patients of choroiditis. And sometimes the situation is like this, that this is really very difficult to tell that this is choroiditis or an entity which is closely mimicking with choroiditis. So, this was a gentleman of 28-year-old who was treated elsewhere with steroids for supposed to be a choroiditic lesion. But the vision deteriorated, and on investigation what we found that it was a case of multifocal CSCR, which was actually thought as a choroiditic lesion. Then again, this is a 32-year-old lady who was treated elsewhere with steroids for serpiginous choroiditis, but the patient was not responding. We investigated and we found that this was a case of choroidal osteoma. So in such scenarios, it is really very difficult to assess that whether this is a choroiditic lesion or a non-choroiditic lesion. And the real problem occurs to decide whether this is a choroiditic lesion or a retinitis lesion. And I think that Dr. Mudit has very well illustrated that difference between the retinitis and choroiditis in the previous session. So if it is a choroiditic lesion, we will have to decide that whether this lesion is a solitary lesion or the lesion is a multifocal one, or whether the lesion is associated with neurosensory detachment. Now coming one by one. So if we see a patient having dense vitritis with focal necrotizing choroiditis, giving typically a headlight in the fog appearance, we should suspect that it's a case of toxoplasma, and when the lesion is healed, it gives a typical cartwheel appearance due to well-defined borders with central retinochoroidal atrophy and peripheral RPE hyperplasia. We can see the choroidal vessels of Bayer's sclera in the atrophic central area. But sometimes this toxoplasma can present with satellite lesions, and the reactivation of lesion is usually seen at the margin of the old scar. And when the element of vasculitis is there, we can see the pattern of chyliosis arteritis. The lesions of toxocora also has vitritis, but the amount of vitritis is lesser in comparison to the toxoplasma. Mostly we see a white grey round elevated lesion of 1 to 2 disc diameter size at the posterior pole in the vicinity of disc or in the subfoveal area. But we can also encounter a peripheral granuloma which appears as a hazy white elevated reaction in peripheral fundus associated with retinal fold, which may extend from peripheral mass to optic nerve head. Since we are living in India, which is very much prone to have tuberculosis, so we should always think of tuberculosis while dealing with choroidal lesions. And tuberculosis can present as a large tuberculoma ranging from 3 to 14 millimeter in size, presenting as a subretinal mass with surrounding subtle serous retinal detachment. But we can also encounter multifocal lesions of tuberculosis, starting from the lesions like millets to 1 disc diameter with indistinct border and surrounding edema with or without hemorrhages and exudate. Sometimes tuberculosis can present as a subretinal abscess, which actually presents as a solitary yellowish-white circumscribed mass-like subretinal lesion and often associated with overlying retinal hemorrhages. As Reema Madam has discussed about the serpiginous choroiditis, the lesions of serpiginous choroiditis presents with irregular, grayish-white, creamy in nature, seen near the optic disc and extending centripetally in a pseudopodial or serpentine manner, but without vitritis. Non-contagious skip lesions has also been noted, and healed lesions shows extensive chorioretinal atrophy. Active lesions are usually found at the border of inactive lesions and appear in an interlocking polygonal pattern that spreads out to the periphery. Again, the serpiginous-like choroiditis, how to differentiate with serpiginous choroiditis? The element of vitritis is present in the patients of serpiginous choroiditis. It is thought to be immune-mediated hypersensitivity reaction in the presence of acid-fast bacilli in the choroid or RP, and the lesions are almost similar to the serpiginous choroiditis. Sarcoidosis closely mimics tuberculosis, and they can present as a solitary granuloma, but in majority of the patients, the lesions are usually small, discrete white spots of 1/3 disc diameter size to pinhead size in clusters around the venules and often limited to 1 or 2 retinal quadrants, frequently inferior and nasally. But they can also present as yellow-orangish lesions located at the level of choroid, predominantly in the posterior and nasal fundus. Sarcoidosis can also present as an optic disc granuloma and in the form of neuroretinitis, and when element of vasculitis is there, we get a typical candle wax drippings-like appearance. Now, multifocal choroidal lesions. Multifocal choroiditis with panuveitis, as the name suggests, the lesions are multiple. They are oval yellow grayish lesions seen throughout the posterior pole and mid-periphery, and they have a distinct propensity for a peripapillary and nasal, mid-peripheral and peripheral distribution of these lesions, and optic nerve involvement is seen in around 1/3 of these patients. Multiple evanescent white dot syndrome is usually unilateral, and they are very subtle, small lesions seen over the posterior pole, involving in the perifoveal and peripapillary regions, and they are best appreciated by slit lamp biomicroscopy, and uniform macular granularity is the hallmark of mutes. APMPP is usually bilateral, but sometimes the other eye involvement may take several weeks, and these are placoid yellowish white lesions seen over the posterior pole and extending up to the equator. The punctate inner choroidopathy is commonly seen in young myopic females, and multiple discrete flat yellow round lesions are seen at the posterior pole. With the time, they are either faded with chorioretinal lesions or atrophic chorioretinal scar. But remember that absence of vitritis, cystoid macular edema or disc edema is not seen in the patients of PIC as we see in the patients of multifocal choroiditis or mutes. Amphigenous choroiditis mimics placoid lesion of APMPP and Quercus lesions of serpiginous choroiditis. Suspect VKH and sympathetic ophthalmitis if we are seeing a patient who is having bilateral disc edema with multiple exudative retinal detachment pockets with anterior and vitreous inflammation. In the convulsant phase of VKH, we get typically sunset glow fundus, and in the patients of sympathetic ophthalmitis, we get Dehlen-Fuchs nodules, but remember that these are seen only in 1/3 of these patients, and the history of trauma actually differentiates between the VKH and the SO, and systemic features are more commonly seen in VKH than in the patients of sympathetic ophthalmitis. So now summarizing, if we are having solitary lesions with vitritis, think of toxoplasma, toxocara, sarcoidosis, tuberculosis, and mascaraders. If we are seeing solitary lesions without vitritis, think of serpiginous choroiditis and mascarades. If we are seeing multifocal lesions with vitritis, think of multifocal choroiditis, mutes, SO, and VKH. If we are seeing multifocal lesions without vitritis, think of APMPP, PIC, and amphigenous choroiditis. And if we are seeing the patients of neurosensory detachment, think of VKH, SO, and mascarades. So the take-home message is that meticulous clinical evaluation of choroidal lesions helps in determining the clinical entity. And these are my acknowledgements. And thank you so much.
Thank you very much, Dr. Tomar. So the next speaker is going to be our Manisha Agarwal, and she's going to talk about exudative retinal detachment in uveitis.
So a very good morning to all of you. In the coming few minutes, I would be speaking on association of exudative retinal detachment in various uveitic entities. So we must understand that exudative RD is a potential complication of any ocular inflammation, and it is primarily because of the damage to the retinal blood vessels or RPE secondary to inflammation. However, the site of inflammation is extremely important in predicting the risk of development of an exudative RD. And if you have inflammation involving the posterior uvea, it has a higher propensity to develop exudative retinal detachment, examples being a posterior scleritis, a posterior uveitis, and panuveitis. The common causes of exudative detachment in uveitis can be any one of
these. Are you forwarding the slides? Because
yes, I am. Sorry?
Here it's not. I thought you were just introducing.
No, I'm very much forwarding it here.
Can you move
Can
the
the AV
slides,
team
please?
help me with forwarding of the slides?
Yeah, there are. I'm looking at it.
Thank you for telling me that, ma'am. I didn't notice. So these are the common causes of exudative retinal detachment in uveitis, and this is the list of differentials that you should have in mind. As far as eye diseases are concerned, the most common being a posterior scleritis, a multifocal choroiditis, APM PPE, primary or secondary panuveitis, sympathetic ophthalmia, TB, and masquerades. And systemic diseases, we can have VKH, rheumatoid arthritis, and SLE. I'll just give you a few case examples. This is a young female with diminution of vision in right eye for last 1 week along with headache. And what you find is a pocket of fluid with ILM striae with a hyperemic disc in the right eye. And when you do an OCT, you have a bumpy RPE and choroid with a pocket of the fluid. However, what you see in the other eye, which is appearing to be normal, that there's an evidence of a choroidal thickening. And when you do a fundus fluorescein angiography, you do see hypofluorescence secondary to a choroidal inflammation, and you do have multiple pinpoint leaks, which are suggestive of an inflammatory pathology. So this patient is actually having acute VKH and treated with IVMP followed by oral steroids and immunosuppression, and she is seen to be responding extremely well in as short a time as a week. This is another lady, 60-year-old female patient with pain and diminution of vision in the left eye. And again, what you see is exudative detachment at the posterior pole. And you have, again, a very bumpy RPE and choroid along with the pocket of the fluid. And when you do an FFA, you find that there are multiple leaks spread throughout the fundus with a hot disc, and some multiple pinpoint leaks are also appreciated. When you do a B scan, you do find an acute scleral thickening along with a very typical T sign suggestive of a posterior scleritis in this patient. So a clearance is taken from the physician and the patient is treated with IVMP followed by steroids. And this is the timeline of the patient where you see that the patient has recovered a good vision with complete resolution of the fluid at the posterior pole. This is another patient where the right eye was a thicycle eye and the left eye again shows an extensive exudative retinal detachment. And on slit lamp examination, you have a granulomatous KP and you also see retrolental cells. So this very much is suggestive of sympathetic ophthalmia treated again with high-dose steroids and immunosuppression. And though non-infectious etiologies is the title of this session, but I thought it would be incomplete if I don't show you an example of a TB granuloma, which again is very classically associated with an exudative retinal detachment. And we've done this work where we have treated these patients with anti-VEGF and moxifloxacin intravitreal injections. And you find that these patients have responded extremely well with complete resolution of the fluid and with the scarring and resolution of the granuloma. This is my last patient diagnosed to have VKH and treated with the high dose of steroids, and the patient was not responding, so she was subsequently treated with methotrexate, still not responding, so azathioprine was added. And there was really absolutely no relevant past systemic history. There was an extensive exudative retinal detachment that you find in the right eye. You also have a hyperemic disc which can confuse you with an inflammatory pathology. This is the left eye where you have again a total exudative retinal detachment with a subretinal gliotic band passing through the macular area. And when you do an OCT, you find that there is SRG bands with pockets of fluid. Anybody is likely to get confused with the diagnosis of a VKH in this patient. When you do a fundus fluorescein angiography, you again find a very hot disc with blurred margins, suggestive of an inflammatory pathology. You have these pinpoint leaks, again, which can confuse you with a VKH or a posterior scleritis. But what very strongly went against an inflammatory pathology was that this patient was not responding to steroids and also to the addition of 2 immunosuppressants in this patient. So we went back and reassessed the OCT of this patient, where we were able to notice these very subtle choroidal bumps which went against the diagnosis of what had been done in the past. So when we went back to the patient again, a detailed history taking, she gave a history of a small nodule in the right breast 2 years back, which was diagnosed to be benign. And we referred her for a re-evaluation of this breast lump. And rightly so, she was diagnosed to have lumps in both the breasts with matted axillary lymph nodes. And after a battery of investigations, she was diagnosed to have metastatic carcinoma of the right breast with leptomeningeal metastasis and both high choroidal metastasis and bone metastasis. So to conclude, active inflammation is the key predictive factor associated with the development of an exudative retinal detachment, and it does require early and a vigorous control. Unlike a rhegmatogenous retinal detachment and a tractional RD, medical management is the mainstay of treatment for an exudative RD. However, exudative RD may have an underlying fatal condition, and therefore always remember to rule out the masquerades. Thank you so much for your patient listening.
There's 1 minute time for any questions. Thank you, Dr. Manisha, for the excellent cases. I invite the next speaker, Dr. Dipankar Das. He's a senior consultant at Shankar Dev Netralaya. He'll be speaking on masquerades, the good, bad, and ugly.
Good morning, respected chairpersons and ladies and gentlemen. Well, I do not have any financial interest in this presentation. This is purely an academic one. Well, masquerades, when Dr. Somashila gave me a topic, good, bad, and ugly, I was a bit confused. Now you see, there is a common masquerades are non-malignant masquerades, which can be good or bad, sometimes worse also, and which include retinitis pigmentosa, then juvenile xanthogranuloma, pseudoexfoliation syndrome, intraocular foreign body, either a iron foreign body or copper, retinal detachment, which includes a exudative and rhegmatogenous retinal detachment, and ocular ischemic syndrome. Now you see, for retinitis pigmentosa to present as a vitreous cells, these are very fine vitreous cells, and you have a classical triad of retinitis pigmentosa where there is a perivenular pigmentation, then arterial attenuation and optic disc-pallor. Patient usually present with night blindness, and you have symptoms as well as signs for it. For juvenile xanthogranuloma, this iris can be involved with a granuloma. There may be a hyphema, recurrent hyphema, which is very, very important. And for systemic juvenile xanthogranuloma, you always look for the xanthoma elsewhere. For example, back of the patient, there may be reddish color xanthoma, which give a clue to you. Now, pseudo-exfoliation syndrome, again, this is a where symptoms and signs are very, very important. But in science, you get a Krukenberg spindles.
Are your slides moving?
Not moving? No, not moving. I'm just pseudo-exfoliation, if you see, Krukenberg spindle. But Krukenberg spindle in basically in pseudo-exfoliation have a diffuse pigmentation, unlike other, and intraocular foreign bodies basically has copper and iron deposition. And retinal detachment sometimes has a pigmentation and can confuse it uveitis, which is called a Schaeffer sign. And in ocular ischemic syndrome, again, this is very, very important because these are very, sometimes can be fatal because of the ischemic syndrome. Now, the ugly part, which I am focusing much more, can be in children, retinoblastoma, metastatic carcinoma in the adult as well as in children, vitreoretinal lymphoma, carcinoma-associated retinopathy, and melanoma-associated retinopathy. Most important thing is the history, very, very important, methodical clinical examination, ancillary investigation, and cross-consultation from the other specialists. Now you see, I'm showing you 6 pictures of all tumor masquerades, okay? And this patient presented with, and I found with investigation, all of them have a cancer sitting underlying. So in vitreoretinal lymphoma, basically an older patient are present with this, male mostly more than female. You can see in immunocompromised as well as immunocomponent. Most important coexisting that they exist with CNS lymphoma, and bilateral is around 80%. Patient present with blurry vision or floater. In slit lamp examination, the cells are a bit larger, vitreous cells. They can be in sheets or haze maybe there. Fundus, there's a multifocal cream-colored subretinal infiltrate. This is a photo shared by Professor Manfred in 2007 to me and showed a multifocal involvement, and this usually lacks cystoid macular edema. Now, fluorescent angiography and ICG can give some clue, but most important is that in OCT you get nodular hyperrefractive lesion in the RP, and for the tissue diagnosis and the fluid diagnosis, you can do a vitreous step for cytology for atypical large cell lymphoma cell, flow cytometry for CD3, CD20 and other, and PCR for D88. This is basically a genetic location and alteration of IL-6 and IL-10. Brain and spine and MRI is very, very important, because if you get a poll, I remember Professor Manfred once asked in IOSG conference, please raise your hand, how many people will do MRI scan in a lymphoma case. Everyone raised in the hall. That's so important because they coexist with the CNS lymphoma. Current treatment not curative, systemic and chemotherapy treatment is advocated. Local therapy include intravitreal methotrexate, and this is repeated injection are given and rituximab. Prognosis is very, very poor. Second masquerade, I'm showing me a 6-year-old child sent from a remote place from our area, and with a diagnosis of intermediate uveitis. In the arrowhead, you see there is a infiltrate. These are the infiltrate in the acid here, and see the pupil is constricted. Immediately I dilated the pupil, and immediately there is an endophytic retinoblastoma in this case. Other is normal. There's a mild dyshyperemia in the right eye. So this patient had a small seeding as well as infiltrate in the antechamber. UVN was given, and MRI showed the involvement of the retinoblastoma. So iris neovascularization can be seen in 50% of the cases in a diffuse retinoblastoma. Pseudohypopian, which is around 32%. There were RB seeding can be seen, or iris nodule in 18%. Hyphema can be presenting features. So if you get a hyphema in a child, there may be retinoblastoma seeding. So if ideally you should not take a acetate for draining. But if you drain it, you send for the cytology, you can get a harbor a retinoblastoma cell. B-scan ultrasound, MRI, and acetate sometimes is done. This is again a case of 87 years old lady with post-cancer breast, diagnosed 3 years back, and post-chemotherapy she was receiving, and there was a post-pleural effusion. There was an iris growth which can be seen here. The patient was insisting because she was told by the radiation expert that we need to have a metastatic evidence. So I immediately done an MRI scan which showed involvement, even the ciliary body, and the acetate showed the hyperchromatic nuclei with scanty cytoplasm consistent with adenocarcinoma of the breast, and this was later on the patient was given radiation and extended chemotherapy. See, this is the atypical hypopia. Such superiorly everywhere, and there was a adenocarcinoma from GIT was in this patient. So in MAT carcinoma, occasionally masquerade as uveitis. Most common intraocular malignancy is the secondaries. Lung from male, breast carcinoma can metastasize in the eye. There may be variation of other tumor also. Uveal tract is the most common site, and remember this thing, 25% of the patient presenting with choroidal metastasis to ophthalmology may not have history of cancer. That's very, very important thing. So the take-home message is that pseudohypopian in extreme age is an ominous sign. In pseudohypopian, The dilated fundus examination is very, very important. High index of clinical suspicion and prompt investigation of the mass queries. Thank you for patient hearing.
Thank you, Dr. Dipankar, for that wonderful talk. Any questions from the audience for Dr. Dipankar? If not, then we'll move on to the next talk, and we have Dr. Abhilasha. She's from Neuroretina Institute. She's a senior consultant there in Hyderabad, and she'll be speaking to us on the white dot challenge.
Thank you, Dr. Manisha, and I thank Dr. Somshila and the AIOS Scientific Committee for this kind invitation. And the white dot syndromes are a challenge to diagnose and to treat. So we divide them into placoids, which involve the choriocapillaries, and they include serpiginous-like, AMPI, and amphigenous choroiditis, whereas punctate inner-choroidopathy, multifocal choroiditis, mutes, and azure mainly involve the outer retina and the RPE. Now, serpiginous choroiditis is an idiopathic condition. It is an idiopathic posterior uveitis where you see a typical serpiginous pattern, and there is a leading edge. And on autofluorescence, you see that the active lesions are hyper-autofluorescent, while the healed lesions are hypo. On the OCT, you see the photoreceptor layer is disrupted. There is outer retinal hyperreflectivity, and there is localized increased thickness of the choriocapillaries. Now, this is the follow-up of this patient, and progressively you see that there is reperfusion of the choriocapillary slab, and there is also regeneration of the outer retinal layers with treatment with immunosuppressives. Now, TB serpiginous-like choroiditis presents a similar picture. Here, the lesions are multifocal and they coalesce, giving the appearance of a serpiginous choroiditis. So, this diagnosis should be kept in mind in TB endemic areas like ours. And here, there is staging in the fundus autofluorescence, where the active leading edge is hyperfluorescent and the inner healed areas are hypo. On OCT, you see that the choriocapillaries are hyporeflective. There is hyperreflectivity of the RPE, and you can also see the double layer sign here. And there is localized thickening of the choroid. Again, this is a 9x9 mm scan of the choriocapillaries, and here at presentation, you see that there is hypoperfusion, a large flow void, and as the lesions heal, there is reperfusion. It's very important to differentiate these two conditions because the treatment is very different. So TB serpiginous-like will present with vitritis. There are multifocal lesions with coalesce, and new lesions may appear anywhere. It's not like autoimmune serpiginous where they spread centrifugally. So these differences should be kept in mind. So this is the first pearl. Going on to the next set of diseases, AMPI. This patient presented to me when she was almost healing. So this is the case of APM-PPE. Early fluorescein angiogram shows hypofluorescence, and late shows staining. Unlike serpiginous, here all the lesions are of the same age. And when they are completely healed, they generally heal without treatment. When they are completely healed, on fundus autofluorescence, they show variable hypo and hyperpigmentation depending on the level of RP atrophy. And this is the Octa scan, where you see that there is reperfusion in the CC slab, and there is complete resolution of the outer retinal layers. Now, amphigenous choroiditis, unlike AMPI, presents as multifocal lesions not only in the posterior pole but also in the periphery, and it spreads very, very quickly. Here again in the autofluorescence, you see active lesions are hyper and inactive are hypo. There is disruption of the outer retinal layers and increased choroidal transmission. With treatment, there is regeneration of the outer retinal layers. This disease, unlike AMPI, should be treated aggressively with systemic immunosuppression. There is high chances of recurrences. Again, here the healing is with a lot of pigmentation, and if you see the Octa, there is reperfusion with treatment. So AMPI presents after a prodrome of flu-like symptoms. In amphigenous, there is no prodrome. The bilateral placoid lesions are mostly in the posterior pole in AMPI, whereas in amphigenous they can spread to the periphery, and the course in amphigenous is quite aggressive and prolonged, and treatment is required with local and systemic immunosuppression. Coming to PIC and multifocal choroiditis. So punctate in a choroidopathy presents as small lesions less than 250 microns in the posterior pole, punched out lesions. Now healed lesions are hypofluorescent on FA, and active lesions are isofluorescent on FA, whereas they are hyperfluorescent in the late phase. When the lesions are healed on fundus autofluorescence, they show complete hypoautofluorescence. On OCT, you see a subretinal hyperreflectivity. There is splitting of the RPE in Brooks membrane. So although it is known as punctate inner choroidopathy, it's actually a disease of the RPE and Brooks membrane. Coming to idiopathic multifocal choroiditis, here, unlike PIC, patients present with vitritis, and the lesions may be in the mid-periphery as well as the far periphery, unlike PIC. You also see these Schlegel lines, which are these are tension lines at the RPE, and these are very typical. This is a diagnosis of exclusion. We should rule out other granulomatous diseases like TB and sarcoid. Again, fundus autofluorescence, active lesions are hyper, inactive are hypo. These patients, even after treatment, should be followed up. This patient was treated 4 years ago, and she came again with fresh decrease in vision, and I did a fluorescein angiogram. Here you see there is leakage on fluorescein, but we don't know whether there is reactivation of the inflammation or there is inflammatory CNVM. So OCTA helps in these patients, so they should be followed up with OCTA. So the third pearl is punctate inner choroidopathy. Lesions are small, mostly in the posterior pole and without vitritis, whereas multifocal choroiditis, lesions are large, extend up to the mid-periphery, and there is vitreous inflammation. These are diagnoses of exclusion, and follow-up with OCTA is necessary to look for inflammatory CNVM. Coming to mutes. Now, mutes is a disease of the photoreceptor layer, and we see small dots, less than 200 microns in the posterior pole, and larger spots which go up to the mid-periphery. Hyperautofluorescence is seen due to unmasking of the RPE because there is loss of the photoreceptor layer. So on OCT, you see there is photoreceptor loss, and there are hyperreflective lesions in the outer nuclear and outer plexiform layer, which co-localize with the dots. They heal without treatment, and patients present with visual field defect and enlarged blind spot, and this is after healing. So mutes is a transient inflammation of the outer retina, and it heals without treatment, usually in 3 months. Coming to acute zonal occult outer retinopathy, or AZUR, here patients present with blurred vision. The onset is slow. There are zones of RP atrophy. So we see a typical trizonal pattern. There is a normal periphery, a demarcation line which shows speckled hyperautofluorescence, and central confluent hypoautofluorescence. Again, the same features are seen on OCT. So this is also a diagnosis of exclusion. Now this particular case was being treated as AZUR. He was on steroids for the past 4 years, on and off steroids. But this is actually a case of CSR. And here we do not see the trizonal pattern. So AZUR is a diagnosis of exclusion. Trizonal pattern is characteristic, and there is no definitive treatment. So to summarize, pattern recognition is key in the diagnosis of white dots. Multimodal imaging helps to distinguish one entity from another, and non-invasive tests like autofluorescence and OCTA should be used for follow-up. Thank you.
Thank you, Dr. Abhilasha, and I think that's the best you could have done in 8 minutes for a topic as wide as white dots. Moving on to the last talk of this session, it's by no other than Dr. Francisco Pichi. He's a staff physician at Cleveland Clinic, Abu Dhabi, and he would be speaking to us on retina vasculitis, a comprehensive review and evidence-based treatment algorithm for inflammatory
Manisha, I think
CNVs.
these are two topics combined together. So he's speaking on evidence-based treatment of ICNs.
Okay, ma'am.
I think two topics are it.
Yeah, that's what I was wondering, that this was really not making any
I checked
sense.
with him. I said, that's a complicated topic you've given.
So I
Sam."
can talk about one topic only in 2 hours.
So
leave.
which one have you picked up?
Evidence-based treatment algorithm of ICNVs. Thank you very much. Very nice introduction. So it's a pleasure to be here. These are my financial disclosure, but they're not really relevant to the papers you're going to see. Inflammatory CNVs are the third type of CNV due to uveitis, and you all know that they're mostly associated with multifocal and PIC, and they're mostly type 2 because we're talking about young patients where the RP is very adherent to the brook, and so the blood vessels, they sprout through. Now, if you look at what's the cause, it's very different. It's quite different from wet AMD because here you have a lot of inflammatory proteins and VEGF. In the pre-anti-VEGF era, there were steroids, PDT that you could use together with immunosuppression. But nowadays, we have a way to stop the inflammatory trigger and a way to stop the immunosuppression trigger. Now, if you look at the literature, there's a lot of paper, retrospective case series, and what's fun is that they use a lot of different ways for these anti-VEGF. Some goes PRN, some load, so there's no consensus. And the only prospective study that was done was the Minerva study that was supported by Novartis at the time, and it's for ranibizumab in everything else that's not wet AMD and DME. And you can see here the results, but it's not really telling us a lot about inflammatory CNV. So overall, anti-VEGF are very effective, and they control, but the control of the underlying inflammation is very, very important. There's tons of different regimens used, so which one is the one that we should use? So we're going to start by presenting a paper that we published on BJO together with Alessandro, and I believe Dr. McCluskey was also part of this. Here, we compare two regimens of anti-VEGF, one loading and PRN, and the other one PRN. We looked at the outcomes of the vision, and we looked at the number of injections and the number of recurrences. So all the patients were treatment naive, so no bias in that. And then, as I told you, two groups. The one had 3 monthly loading and then PRN. The second one went PRN from the start. Now, this is the best corrected visual acuity at baseline in the two groups, very comparable. These are the causes of the inflammatory CNVs, and these are the results, which are the most important. You can see at 24 months, the changes in best corrected visual acuity and the changes in the number of letters, they are very comparable between the two groups. The dotted line is the PRN, and the other line is the loading plus PRN. So there's no significant difference in best corrected visual acuity at 24 months between the group that was loaded then treated PRN and the PRN group from the start. What about the number of anti-VEGF? It doesn't take a genius to understand that if you load the patient, you get more injections done. So here you can see in the loading group, there's a mouse here, yes. In the loading group, there's a higher number of anti-VEGF injections at 12 and 24 months. So overall, the loading group received more significant number of injections compared to the PRN group, both at 12 and 24 months. What about the recurrences? They were quite few in both groups. See, both in the loading and the PRN group, they're very comparable. So no significant difference in the number of ICNV recurrences. So it has some limitation because it's retrospective, it's not standardized treatment, but it's a start for us to tell that patients can be treated with anti-VEGF PRN when they have inflammatory CNV. Anti-VEGF were effective in our group, and the loading phase did not give any advantage to patient treated PRN from the start. So PRN seems to be the best way. But what about treatment? Because we are injecting, but at the same time we are treating the patients systemically. So we just published this paper where we are evaluating patients with inflammatory CNV divided in two groups, one treated with steroids, PRN, and the other treated with the immunosuppression. Now these are the baseline characteristics, very comparable between the two groups, between the steroids and immunomodulatory group. The results, best corrected visual acuity at 2 years, you can see straight away, you can see from here that there is a slight difference between the group that was treated with steroids and the immunosuppressed group, but you can see it much better here. If you look at the green line, these are the patients who received immunosuppression, and they gain many more letters compared to patients who were treated on PRN oral steroids. And it's same thing for the change in visual acuity from the baseline. What about the number of recurrences? You will see that patients who were treated with steroids PRN, they have a higher number of recurrences compared to patients who were immunosuppressed. So this is the number of recurrences reported in a graph. Steroids as needed has a higher number, significantly higher number of recurrences compared to the patients immunosuppressed at year 1 and more at year 2. And of course, the number of anti-VEGF injections that were used were higher in patients that were treated with PRN steroids compared to immunomodulatory treatment. And here is the Kaplan-Meier. So if you immunosuppress a patient, the recurrence of inflammatory CNV takes longer to happen. So in conclusion, immunomodulatory treatment was associated with lower reactivation of ICNV, lower need for injections, and better visual acuity compared to just using steroids oral when needed. So immunomodulatory treatment should be considered in all patients with multifocal choroiditis, especially those that have an ICNV, given the great positive impact. And with this, I thank you very much for your attention.
Thank you, Dr. Picky, for that excellent talk. Any questions from the audience?
So I have a question for Dr. Vishali. That we have the first talk on patterns of choroiditis, ma'am, and so for the benefit of all of us, on clinical examination, when you see a patient of choroiditis, what would be the signs that you will look for which will make you suspect a tubercular etiology as the underlying?
First thing is, when I look at the choroiditis, I do OCT through the lesion, and I see whether it is retinochoroiditis or it is chorioretinitis, which is the primary site of involvement. If it is retinochoroiditis, where retina is primarily involved and choroid is just secondary, TB is highly, highly unlikely. If it is primarily choroiditis and retina, especially the outer retina, is showing changes, TB is more likely the cause. Now, the way TB can present in the choroid could either be serpiginous like choroiditis, and you saw the beautiful pictures, Rima and Abhilasha, like how would you look at serpiginous choroiditis, which is self-explanatory. It's multifocal. It has a yellowish border, heals in the center. It may have some cells in the vitreous and AC. It may have peripheral vasculitis. None of this will happen in non-TB. So serpiginous is sorted. The second is a granuloma in the TB. If you see the granuloma which is single, which is large, which is yellow, which has retinal hemorrhages and new vascularization in the form of the RAP, the diagnosis is likely to be TB.
Thank you, ma'am.
I have a question for Dr. Picky. Thank you so much for the excellent talk on inflammatory CNVMs. In your practice, which is the most common disease that you see, inflammatory CNVM, and do you see any benefit of combining a local steroid with an anti-VEGF?
Mostly multifocal choroiditis or PIC, which maybe are the same entity in the end. And yes, so there was a paper where Annie and Ale were part of it some years ago, I think it was 2019, where they also proved that immunosuppressing patients with multifocal choroiditis reduces the area of atrophy. So I have zero tolerance for multifocal choroiditis, so I tend to immunosuppress them. Maybe PIC is slightly different. It depends on the number of reactivations. And then yes, I do, in every patient with multifocal choroiditis, I do an OCTA because, the inflammatory material can look like an inflammatory CNV sometimes, so an FA is not always helpful. If there is flow, I do inject. I inject PRN. I get away with maybe a couple of injections most of the time, 1, 2, maximum 3, and by immunosuppressing them, I get quite a good result.
Dr. Pichi, I wanted to ask you, since you're so much into imaging, what would be those signs on OCT, especially OCT, where you would be highly suspicious of any kind of a choroidal mets or a masquerade in a patient?
Choroidal mets. So in my, I was looking at the cases. So the few cases of choroidal mets that I've seen, they're not so huge. So there was a question if it was VKH, right? So to me, VKH has a choroid which is diffusely blackish. You don't see the vessels, you have the RP undulation, whereas the metastases that I've seen in the choroid, whether coming from the breast, I've seen a couple from the lungs, they are huge sometimes, but they are contained. So you have the masking effect like a nevus, more or less, masking effect behind, but the choroid around is not affected. So that's what I would look for.
And what about the undulations? Because we see those choroidal and RP undulations in posterior scleritis, VKH, as well as in choroidal mets. So sometimes that is something which really, confuses us what really we are dealing with.
Yeah, I think undulation is just mechanical stuff. So something pressing from behind gives you a bump. So I don't think we should rely on those, right, because it's just mechanical.
Right. Any questions from the audience?
I do have a question about AMPI. How often do you see AMPI in India? You don't see, okay. Because there's also the matter of vasculitis, of brain vasculitis. So there's a very nice paper that just came out, don't ask me when, this month in some journal, and they're looking at the preponderance of retinal vasculitis, of brain vasculitis in patients who have AMPI, and it's higher than I would expect. So you're lucky that you don't have it maybe here, or
very,
not so
very
much.
rare. I think the case that I presented, this patient was actually referred. So this patient is a patient of microscopic polyangiitis, P-ANCA positive, and she was, the diagnosis was already there. She just came, she was referred for an ocular examination by the rheumatologist.
Gotcha. But yeah, always be mindful in case.
Yeah, and probably we might even be missing because it's very subtle and it kind of resolves without treatment. So it is a possibility that we might be missing some.
So thank you so much. We've had a wonderful session with some excellent talks and discussion. And we hereby end this particular session and move on to the next one. Thank you, everyone.